you had 10 different people giving this talk. I'm sure you'd have multiple iterations of it. But the plan here really is to try, I think, oh, maybe I'm using this one here. My apologies. Can't seem to move us ahead, so maybe we can just move on to the next slide. There we go. Is to review, as evidenced by your first question, that there are lots of options. And thankfully, myeloma is really no longer a disease where we say, this is what you do front line, this is what you do second line, this is what you do third line. There's so many factors that go into influencing that. So we'll review some of those options and try and help us appreciate what we've really come to learn in the last 2 to 3 years is how to leverage those combinations together, obviously in theme with our discussion today. I will comment on the importance of transplant for that 32% of you who do not want to refer our patient for transplant. Not that it is a mandatory phenomenon, but I think we have learned, of course, that it is still has a role in myeloma. And then I like to say strategy, not script, in terms of how we approach relapse disease, so that you don't just have a 1, 2, 3, 4. If you want to nap for the next little bit because you've just had some good lunch and you're a little bit postprandial, then this is really the summary of it. And the fourth point will come into our second lecture after Bill speaks. But the overall themes are we're treating patients for longer. Right? We haven't cured myeloma. We haven't cured high blood pressure or diabetes either. So we're chronically maintaining these patients. Whether they're transplant eligible or not, in general, the majority of patients are going to have continuous lifelong therapy. Now, it's not absolutely mandatory in everybody. I've seen some situations where, like, you're going to take it and you're going to like it. There is a point at which we can stop therapy. That was a joke, by the way, just to warm you up, just to let you know when the laugh meter should be here. But it's important that we've come to appreciate in certain risk populations, especially the highest risk patients, continuous therapy is critical. We've also come to appreciate that A plus B can be superior to A then B. Now, the caveat to this always is, and this is in theme of our day, if I do any kind of trial that shows 3 drugs versus 2 drugs, unless they're particularly toxic, 3 is always going to be better than 2. 4 is always going to be better than 3. 5 is always going to be better than 4. So we have to be careful in interpreting the results of trials that say, oh, KRD was better than RD, therefore in every eligible patient, I'm going KRD because I want the very best for my patient. That's a dangerous phenomenon, and we'll talk a little bit about that as we go. And then we'll come back to immunotherapy later. So we are improving survival in myeloma. No disrespect to our lymphoma colleagues for the morning, but we're winning. But it's still a tragic disease, of course, but on average now, you can tell your patient coming into the clinic next week, unless they have high-risk myeloma, which is maybe 20-25% of patients max, that we expect patients to live over a decade now, and it could well be significantly longer than that. So how do I initially treat? Generally speaking, we use a bortezomib-lenalidomide combination. That's sort of the centerpiece, although that can be adjusted. Sometimes we may simplify it a little bit and use the so-called CyBorD regimen, cyclophosphamide, bortezomib, dex, in certain populations. And for those who are not eligible, we would often use simply lenalidomide and dexamethasone. But again, now we have strong evidence, as I'll show you, that adding bortezomib, in particular in high-risk disease, but in general, can be a positive. So again, to simplify this, in a setting that Vincent Rajkumar published last year, if they're not a candidate, we generally will go with either RD or VRD based on their frailty. For those who are transplant candidates, generally speaking, VRD with a transplant, generally speaking immediately, but there is some evidence that we can delay transplant as well. Either way, you want to collect cells up front. We'll talk about that. One of the ways in which we can risk stratify patients is what we've used is the M-SMART classification. It may not be that smart, but that stands for Mayo Stratification for Myeloma and Risk Adapted Therapy, where we've put people into these 3 buckets. And if we look back at the last decade, those 3 buckets influence survival dramatically, in that high-risk population still have, sadly, a survival of less than 3 years. The intermediate risk is more like 5 to 6 years, and the standard risk is greater than a decade, as we've mentioned. So you can go to msmart.org if you wish to look it up and see the details. I'm not going to go through this in great detail, but this delineates the general premise of using bortezomib, lenalidomide, dexamethasone up front within that highest risk population, considering switching out the bortezomib for carfilzomib, and we'll have some more, hopefully, evidence of that this year to guide us. So again, you could look at this historically and say, oh, I just use the induction regimen that has the greatest response. And this is my Canadiana coming out here, that it's not just exclusively the highest response rate that we pursue, but these are the ones that we've tended to use the most. Partly because there is obviously a cost implication, and it's not all about cost. It's not just about wallet toxicity, right? It's about clinical toxicity. So unless I really know that moving to a certain regimen adds that much more, we have to be careful, obviously, that we don't induce more toxicity, be it to the bank or to the patient's body, of course, in doing so. One of the most important sentinel trials just published, it was presented as an ASH abstract a little over a year ago, just published last month or 2 months ago now, was the trial that compared bortezomib Lendex to Lendex that was led by Brian Dury. And the key point here is that if you look at the second line of this, that there were over 40% of patients who were over the age of 65, who historically, although in the US we tend to push that to 70, would not have, generally speaking, been considered transplant eligible. And that was purposeful in this study to see, should we really only be thinking about 3 drugs in the transplant eligible and only 2 drugs in the transplant ineligible, or can this work across the board? And generally speaking, as expected, response rate 81 versus 71% was better, and it led to an improvement in progression-free and a trend at least towards overall survival improvement. Now again, caveat that I made earlier, 3 is always going to work better than 2 if they're generally tolerable, but this was encouraging to us to know that this combination is tolerable even in an older population. It of course comes with some challenge, including neurologic, which generally speaking now we try to modulate with a dose adjusting the way we do bortezomib. I can just say flatly, because I give hundreds of patients a year bortezomib, every single time I use bortezomib, subcutaneously and weekly. And I think that's just a simple take-home point, that the days, some of the trials have to still do it twice weekly based on registration phenomenon, but in general, every single patient I'm going to treat with bortezomib, I give it subcutaneously weekly. Often I up the dose a little bit to 1.5 milligrams per meter squared based on some of the studies that we had the privilege of being a part of, and we can talk more about that at the Q&A if you wish. But that really significantly mitigates the neurologic toxicity. It doesn't remove it. There are still some patients that despite subcutaneous and weekly administration will have it, but I would recommend that that really is the new standard of care. Now, to transplant or not to transplant? I remember when the study was being designed, transplanters, like Bill Bensinger and others, were worried. We thought, oh my goodness, because I'm a transplanter too. You know transplanters, right? When you're a hammer, everything is a nail. Like that's what they want to do. They were afraid that this was going to be the death knell to transplant, because we were going to demonstrate that if you just give enough bortezomib Lendex, that for longer, in this generally speaking, think of it as 8 cycles of RVD versus 4-ish cycles of RVD plus transplant. And the thought was, it's quite likely that the RVD by itself will be enough, and this could be the end of transplant. Well, the reality is it isn't. Those patients who underwent transplantation had a deeper response, as you see the differences here in response rates and CR, VGPR, and PR rates, and furthermore, had a prolonged progression-free survival. This is just the depth. Of course, after induction, it should have been the same because they were all initially given VRD. But then after the consolidation with transplant, you see how the transplantation numbers go up here, statistically significantly over the RVD numbers. This also translated into a progression-free survival difference of 34 versus 43 months, or at 4 years of 35 versus 47 months. So there was still a role. That slide that was shown earlier today that I thought was brilliantly done with all the different cards that we have. You know, in a disease where we're not curing patients, I don't want to take cards off the table. Now, granted, transplant is a pretty toxic card, and so you have to consider, I think importantly, in whom it should be given. But I think this gives credence to us that transplant is not dead in the world of myeloma. To complete out our thoughts about initial therapy, this is a highly anticipated trial. I've had a number of patients myself on this study where we wanted to see if carfilzomib Lendex was superior to bortezomib Lendex. And more of this to come. The results are likely going to, at least from a preliminary standpoint, be available by the spring. So probably not at ASCO or EHA, but perhaps in the fall at ASH. The Europeans are doing a similar study, carfilzomib Lendex, carfilzomib Cyclodex, and carfilzomib Lendex, and we'll see with or without transplant to see if that makes a difference. Looking to the future, and again, this is beyond the scope of our discussion today, and I don't want to steal thunder from Bill, but we have a lot of studies. This is the European one, just to show even with thalidomide-based therapies, but we could also see this with VRD. We're considering adding daratumumab up front because obviously the prolific nature of daratumumab as a monoclonal antibody. A little for me to say that we're learning from our lymphoma colleagues, but yes, when you added R to just about anything, it made it better than just about anything, and we're probably going to see the same thing here with DARA. Last point about transplant before we go to thinking about relapse disease is that there is this growing phenomenon because people show that if you get a really deep response before transplant, you're going to do well in the long term, which is not a shock, right? I'm a runner. If I measure who's leading the marathon at the halfway mark, that's probably somewhat predictive of who's going to finish the race well, right? And that's understandable. But what happens is people are saying, oh, no, you can't go to transplant. You need to be in complete remission before transplant. You need to be in a VGPR before transplant. I think that's a little bit dangerous thinking. We could talk later about how deep a response someone should have. I would generally suspect that someone should have a 50% response with the kinds of agents that we're using now. But I see patients getting second, third line therapies up front before transplant. This was just a registry study that looked at what if someone didn't even get a PR after transplant, before transplant, even in those in whom they went right on to transplant, the transplant was the equalizer, as it were. So although depth of response before transplant may be prognostic, it shouldn't stop you from sending someone to transplant because the transplant still has a benefit. So to conclude, RVD is still generally speaking the standard of care. We can give considerations to CyBorD or VTD in the right context, obviously based on what's available. Novel agents have not supplanted the need of transplant, and carfilzomib is a upfront potential option, especially if I have a patient who has known pre-existing neuropathy that I do not want to exacerbate potentially with the bortezomib, and as we saw, watch for monoclonal antibodies coming soon. For transplant ineligible patients, here's the summary. Melphalan is really not the standard of care up front anymore. I'm not saying you can never use it, but in general, don't do it, right? We're not using Melphalan frontline anymore for lots of reasons that we could discuss later if people wish. We're using novel agents, and this arbitrary don't give it for more than 12 or 18 months. We were bound by that because we knew that Melphalan after 12 or 18 months caused a lot of marrow toxicity. So if we're not using Melphalan up front, we can use drugs for longer. I've already commented on dose adjustment of bortezomib, but similarly, as patients get older, it's critical that we use a more conventional or less toxic means of treating them. So in our MSMART guidelines, similarly, a fair amount of VRD here again, perhaps RD in older, more frail patients. And a lot of this is based on this study that I don't want to spend a lot of time on, but it was just updated at ASH a month and a half ago or 2 months ago, where there was MPT or Melphalan prednisone flutamide, which we hardly ever use. But if you even just look at the comparison of arm A and B, which is giving Lendex for 18 months versus Lendex continuously, it was the continuous arm that had the best outcome. And it's interesting that the drop-off there is almost perfectly at 18 months. When people stopped therapy, they started relapsing, which was part of that evidence, if you will, for treating on a continuous basis. I'll skip that just for our time's sake. Let's move then in our last 7 or 8 minutes to relapsed myeloma because, as I mentioned, I don't think it's a script. It's a strategy as opposed to saying, this is what I do. Do you ever get those like surveys? What is your second line therapy for myeloma? And I get like start seizing because I can't answer. It depends. There's no it depends button. But it is very complicated. I like to simplify it by saying 5 questions to ask yourself. Question number 1, do I really need to treat the patient now? You know, we have changed the definition of myeloma. So we used to have myeloma defined by the CRAB criteria, elevated calcium, renal insufficiency, anemia, and bone disease. We've now added 3 features to that. Plasmacytosis greater than 60%, light chains involved over uninvolved of greater than 100, and 1 or more, which is a radiological term, focal lesions on an MRI. Not that we're always doing an MRI in people's marrows, but it does that. Now I've created this little acronym, SLIM-CRAB, because you're going to remember it all. I tried different options. We had crab legs, we had lobster, we had lots of things while we were discussing it, of course. No, but this helps me remember it and hopefully will help you remember it. Now, this is for upfront therapy because really what we're trying to do is cream off the top of smoldering, the most risky smoldering, and putting them into true myeloma. I would caution you against treating smoldering one way and active myeloma another way. I think most of us believe is we're just going to move the line a little bit lower, and if you have myeloma, and you get the best therapy possible. It's not like we're half treating smoldering and truly treating myeloma. So even though this is an upfront therapy, I think it has implications for relapse, that just because someone's M spike is starting to reappear, it doesn't necessarily mean we need to jump in right away. Can I retreat with what I've used before? I mean, I know here in God bless Merkel, we love to start new things all the time. Oh, new shiny thing, right? Let's go to another card. Let's go to another drug. And I say that a little bit facetiously, but in general, we like to go to new agents all the time. But if something has worked before, it's very reasonable to go back, especially if there was a significant depth and duration of response. And then the most important question is, have I employed the big 8? And let's spend most of the last of our minutes just thinking about these big 8 drugs. Now, first is thalidomide. I say thalidomide in American context, and people think I'm cracked, but the reality is this is still a very effective drug. I tend not to use it early on because of the neurotoxicity, but late in the disease course, this is an immune modulatory drug with very little myelosuppression. So in that patient who unfortunately has a significantly burnt out marrow, it can be an add-on agent. We've used a lot of it in combination with bortezomib or carfilzomib or other agents, and that may be of use to patients. Bortezomib, I'm sure you all know, extensively used. I've mentioned already the importance of subcutaneous administration, and it can be used now in multiple combinations, as we're going to hear more about over the day. Similarly, lenalidomide. Most patients now are receiving lenalidomide maintenance. That's really the standard of care after transplant. So often when they're relapsing, they wouldn't have been eligible for all these trials that are guiding us in our treatment. So it's difficult for me to take someone who's relapsing on len and just add something to it. Now, in some circumstances, I may consider that if it's a very slow biochemical relapse before we add in carfilzomib or add in daratumumab or add in one of these other agents like ixazomib. But len progression usually means that we switch off lenalidomide. Carfilzomib, you're quite likely familiar with this drug. Pound for pound, this could be the most potent drug that we have in myeloma. I think of the 3 that perhaps are the most potent right now would be carfilzomib, pomalidomide, and daratumumab. And this is obviously a very potent proteasome inhibitor, very active. There are some challenges. I could refer you to a insomnia curing paper that I wrote recently on carfilzomib and the heart, the untold story. But I think it got a bit of a bad rap, and I think if you carefully manage patients, there really is no one I would exclude from carfilzomib therapy based on their cardiac issues. There are 2 patients who in the clinic tomorrow or next week, I might delay a week with uncontrolled hypertension and uncontrolled heart failure. But just give us time to get those under better control, we can still expose them to the drug. And of course, it's used in multiple combinations. In particular, the most prolific was carfilzomib, lenalidomide, dexamethasone, published in the New England Journal. Pomalidomide, another in the family of IMiDs, again, particularly potent, more potent than lenalidomide, and can be used very much in combination. For lots of reasons, it's not being used upfront. So it's now thought of often as the natural partner to compare with as these newer agents are being approved. And then Dara, and I think you all know daratumumab. It's been approved both as a single agent in November of 15. A year later, it's now approved in combination, 1 to 3 prior lines of therapy, either with lenalidomide or with bortezomib. And of course, this is a very attractive drug because it has minimal overlapping toxicities what we're using. The infusional reaction is real. 50 to 60% of patients have it. That first infusion takes 9 to 10 hours. So they're there for a long day. Obviously, you don't have time to go in detail. There was a very interesting abstract presented at ASH a couple of months ago with a new subcutaneous administration of DARA, where the whole infusion would take 30 minutes. So that might be very attractive in the future. But if you get beyond that initial inconvenience, as it were, this is a particularly active agent demonstrating single agent activity and in combination. I think it's going to have the greatest impact of those 3 drugs that were approved within a month, as I've mentioned. It's the rituximab of myeloma, if we're allowed to use that expression. And watch for other ones in this class, including isatuximab, which is being developed. Number 7 out of the 8 is ixazomib, which is, of course, the first oral proteasome inhibitor in this class. It's not just oral bortezomib, although it's a very similar compound. This is a regimen, as you likely know, is 3 pills a month. Do not drop the pill down the sink, right? Each of these pills are about $3,500, so be careful. And, honestly, I've had the privilege of leading some of the trials with ixazomib using it. It's a very effective drug. It's probably pound for pound, not quite the same as bortezomib and carfilzomib, but when used in combination, it can be very effective, and it's a little less toxic than some of the other proteasome inhibitors. I think we're going to see a lot more ixazomib used in maintenance therapy and in older patients with time. And this was based on the tourmaline study, which compared ixazomib Lendex to Lendex and showed an improvement in progression-free survival of about 5 months. Lastly is elotuzumab, which, to be honest, of all the drugs approved in that 2015 year where we had many of them, it and panobinostat are the 2 that are least used. But it still has clearly an impact here, especially when combined with lenalidomide. It is perhaps not as potent when combined with a proteasome inhibitor, but clearly extends the progression-free survival of patients when they're on lenalidomide and dexamethasone. It also has a very intriguing mechanism in that it's not just an antibody targeting the artist formerly known as CS1 or cell surface 1, which is now called SLAM-F7. Sounds like we're in a wrestling match or something, but it also has this potentiating effect on the immune system, and particularly can encourage T cell activity. And so I think that notion or being able to as it's thought of here as a co-promoter of the immune system is something that we need to understand a little bit better. And the ELO Lendex versus Lendex study showed similar results to what we had seen before, with an improvement in progression-free survival. So this did not have single agent activity, so I don't think it's going to be one of the big kids on the block, but I do think that we're going to see this agent used a little bit more. I know my time is up, but I'll promise to give you a little time off of my immunotherapy talk. So when we summarize what we've had for combination therapies, and I know there's a little bit of comparison here from phase 2 and other trials, but I just wanted to give you a little sense that really often, of course, will depend on lines of therapy. People with less refractory disease obviously are going to have higher response rates compared to those that are late in disease state, with the exception perhaps being the very last bar here. Carfilzomib pomalidomide dex is a particularly potent combination. By contrast, you have a patient who progresses on carfilzomib pom dex, they're generally going to have a challenge. Don't forget the add-on agents. These are agents that will boost the big 8. In particular, obviously, you're used to using steroids and alkylating agents, but panobinostat still has a role, albeit I think somewhat marginal when combined with bortezomib. And lastly, of course, you have to look at the whole of your patient. That's why we can't just say, this is what I use second line, third line, fourth line. Now, if you're really insistent on looking at second line, third line, fourth line, again, at msmart.org, we've tried to provide some guidance. You go to the NCCN guidelines and you've got a laundry list. How can you direct that laundry list? And we've tried to divide it based on whether patients are on maintenance or not, whether they're frail or fit, as it were. And this might give you some guidance. But the theme you see here is, in general, we're combining 2 classes of drugs, either a proteasome inhibitor and an IMiD, a proteasome inhibitor and a monoclonal antibody, or a monoclonal antibody and an IMiD. And so I've tried to, and I won't go through the details of this, so you can look it up online. I've tried to summarize this in this, what I think of as the 4 pillars of myeloma care: proteasome inhibitors, immune modulatory drugs, monoclonal antibodies, and alkylators. Alkylators still have their place, as we discussed with stem cell transplants. And then on the outside, you have, if you will, more minor pillars that help boost the activity of these drugs. It's quite likely in the near future we're going to have a strategy up front that includes all 4 pillars together. Right now, we tend to use 3 out of those 4 sequentially. And those are the physicians I have the privilege of working with. So I will stop there.